Hello, my dear doctors. So, we're going to continue with our consultation station in the new PACES format, which is called PACES 23. And as I have discussed in my previous presentation, that it was going to be implemented very soon, likely end of this year. So, one should familiarize with this type of format. Okay, so today we're going to discuss about the atrial fibrillation, and as you know, this consultation station is a new station, and there'll be two consultation stations actually, 20 minutes each. In the first 15 minutes, you have to take the thorough history, do the focused examination, answer any concerns, and the 5 minutes left will be for the examiner questions and answers. Okay, so we're going to start today, and this is a very hot topic, atrial fibrillation. It can come in your short case, in your cardiology station as well as can present in the long case as well, or the consultation station. Okay, so let's move on. So first of all, obviously, as you know that you have to take a proper history from the patient. So in the let's start with the history today. So we have a 61-year-old man, and he presents to the emergency department, and because of palpitations. And the palpitation, they began about 2 hours ago while he was watching television. As I move on to the history, I'll want to discuss about the salient features of the history, the questions you need to ask, and why these questions are important. We know that if the patient is older, more than 60 years, like in this case, and patient has palpitation for the last 2 hours, so the incidence actually of atrial fibrillation increases with age. So a patient in their 30s presenting with palpitation is far more likely to have some other types of SVT. But in this scenario, the patient is more than 60 years, so the AF is more likely than other types of SVTs. Okay, let's move on. He describes the palpitations as uncomfortable and fast. So this patient actually has a clear onset of symptoms, and that is likely to coincide with the possible arrhythmia AF. AF is usually asymptomatic, but it can present with a wide spectrum of symptoms. Palpitations, actually, these are the common complaints in symptomatic AF, and the patient described them as fast, raises the concern that the patient is also tachycardic, likely with the rapid ventricular rate. Okay, let's move on. He says he may have had similar episodes in the past, but they never lasted this long. Now remember that intermittent episodes of palpitations in the past are consistent with arrhythmias, and in the case of AF, it's likely to be paroxysmal rather than permanent. So it may be helpful to get the patient to tap out the palpitations to establish whether the rhythm is regular, fast, or slow. Okay. So he has no chest pain or dyspnea at the time of presentation. Very, very important to rule out the important negatives with the patient. Coronary artery disease is not very commonly associated with AF, but AF, it can occur transiently in about 6 to 21% patient presenting with acute MI. So the presence of chest pain must be explored. It is known that atrial ischemia due to MI leads to atrial fibrillation. AF and heart failure commonly occurs together, so often an acute exacerbation of heart failure can precipitate AF. So important to ask about the dyspnea as well. What happens that in heart failure, it can lead to the atrial stretching, and that can predispose to AF. Okay, now he has an exercise tolerance in excess of 3 km. So the patient has a reasonable exercise tolerance, suggesting that overall cardiac function is not greatly impaired. It is very important to get an understanding of current exercise tolerance in all patients who presents with cardiac symptoms. And this exercise tolerance is also a significant prognostic factor. Okay. He reports no orthopnea or paroxysmal nocturnal dyspnea. Now, these are the signs of pulmonary congestion and left-sided cardiac failure, which is common in patients presenting with palpitation. He has otherwise been well over the past few days and reports no infective symptoms. Now, infection is known to cause acute presentation of heart failure or any arrhythmia such as AF, and the risk of AF actually increases after infection with influenza virus and pneumonia. It's so important to screen for infections in patients presenting with palpitations. He has a background of alcohol abuse and can drink up to 14 units of alcohol per night. Now, alcohol consumption actually need to be asked in every patient, especially in patients who present with palpitations, because alcohol consumption is a significant risk factor for developing AF. So AF occurs in around 60% of heavy drinkers with or without having any underlying alcoholic cardiomyopathy. Okay, and he has also history of type 2 diabetes, hypertension, asthma and obesity. Now remember that hypoglycemia in the setting of diabetes can also predispose patient to palpitations. So it's important to take a detailed medical history and check blood glucose level. Diabetes is also associated with development of AF. And hypertension, is also associated with increased risk of AF. And chronic airway disease like asthma, COPD, they also can predispose patient to develop pulmonary hypertension and may lead to remodeling of the heart, and this remodeling can be linked to the presence of arrhythmias. Obesity, well, is also linked with complications such as obstructive sleep apnea and right-sided heart failure. So once again, this is because of the remodeling of the heart, and it can lead to disruption of the conduction pathways and arrhythmias. So this history you can apply if the patient has presented with palpitations. Obviously, with the history, we're not sure that what type of arrhythmia is it, but we can have a differential diagnosis in our mind about all the arrhythmias. So after the history, then you will come to the examination part, and here you will get your diagnosis. So patient appears mildly uncomfortable but is otherwise alert. I mentioned these few lines because it is important for you. Once you end your case, then you have to present the case. So you must know what phrases to use and how to present your case. I just mentioned here it smells strongly of alcohol. Actually, in your exams, the patient will not smell of alcohol. It's not really possible. Patient will be sober. Just I have mentioned this line just to be more sure that you should ask about the alcohol history in a patient with any type of palpitations. His blood pressure, okay, is currently 120 by 75, and his heart rate is 155 and is irregular. So now you have done the examination, you have palpated the pulse, and then you came to know that the pulse is irregular. So you already got your diagnosis, there is some irregularity there. So, and then he's not febrile or hypoxic and has a normal respiratory rate. So obviously patients presenting with heart failure or respiratory infection may trigger AF in a patient with an underlying predisposition for AF. So there does not seem to be any respiratory compensation in this patient. So you'll do your cardiac examination obviously in this patient they are present with palpitations, but you're going to do the respiratory examination as well. His JVP is not elevated, but on close inspection A waves are absent. Now this one maybe you will appreciate, maybe you will not, doesn't matter. As long as you can comment on whether the JVP is elevated or not, that should be enough. Anyhow, the elevated JVP is a sign of right heart failure or tricuspid regurgitation. and both these can be the mechanism that can predispose to arrhythmia such as AF. And if the patient is not in any acute heart failure or anything, usually the patient will be quite stable in the MRCP examination. So once you examine the JVP, there is an appreciable apical radial pulse deficit. Now the apex beat can be difficult to palpate, especially in obese patients. So an apical radial pulse deficit, which is seen in AF, where the radial heart rate is less than the apical heart rate. Now, since the heart rate is irregular, so what happens, some contraction will occur with insufficient filling of the left ventricle and results in beats with insufficient stroke volume. So it will not transmit the pressure wave to the arm. So there will be a apical radial pulse deficits. Heart sounds are okay, dual with no added sound. Mainly we're looking for an S3, maybe a sign of a systolic heart failure. If you can find that one, just mention it. Or sometimes can be S4 as well. And this is S4 is a sign of diastolic heart failure or active ischemia. So absence of both is actually reassuring. So these are important negatives which you must look for and mention in your presentation. There is no hemiplegia, weakness, speech disturbance, nystagmus, or vertigo. Okay, so nystagmus and vertigo, these are a sign of a posterior circulation stroke. It is an embolic strokes. In embolic stroke secondary to AF, patient can have multi-territory deficit. So we don't find anything. Just mention it in your presentation. So this was all about the examination. So how will we investigate these patients? So on investigations, obviously, first of all, we want to do an ECG, and we're looking for an ECG irregular rhythm with an absence of P wave. ECG, you will see that there is a narrow complex tachycardia in atrial fibrillation rate of 150 beats per minute. Blood test should be performed, especially we're looking for the serum electrolytes. Here I mentioned potassium of 3.5, just to mention that the potassium level is very important when you are checking you see the irregular rhythm, then must look for the potassium level. Because hypokalemia especially increases the risk of AF compared to normokalemia. So any patient with low potassium should be treated with IV oral treatment to replace the serum potassium. So further tests we want to do is the blood examination. We want to do the renal function and thyroid function as well. Now, the clinical or subclinical hyperthyroidism is present in less than 5% of patients with AF. So thyroid function test should be obtained in all patients with first episode AF or those with frequent exacerbations, as this might be the exacerbating cause. What else we have to do? We like to do the chest X-ray, and the chest X-ray we will be looking for any cardiomegaly or any signs of fluid overload. A bedside echocardiograph reveals a left ventricular systolic ejection fraction of 55% with mild hypertrophic disease and normal valvular function. So this will be the sequence of tests next after chest X-ray. We want to do the echo. We want to make sure what is the ejection fraction of the patient and is there any valvular dysfunction or any stenosis or regurgitation. Normally it is the mitral valve which is involved in cases of atrial fibrillation. This is quite significant because occult mitral stenosis may present with AF. So the absence of mitral valve pathology influences the risk of thrombus formation. So long-term sinus rhythm is often very difficult actually in patients with mitral stenosis unless they have procedure repair. Okay, so there is bilateral mild to moderate atrial enlargement. So these are the things which you find to we like to see in the echo. We want to know the ejection fraction. We want to know whether there is any hypertrophic changes. We want to know about the valve, whether there is a normal valve or any problem with that, and any atrial enlargement. So just a bit about atrial enlargement. Normal left atrial dimension is less than 4 centimeter, and enlargement is actually common with atrial fibrillation. No thrombosis seen in left atrium with the transthoracic. So now these are the sequences. So after the echocardiography in transthoracic, you sometimes need to do the transesophageal echo also, and the transthoracic transesophageal echo is actually, especially if you are looking for any clot there in the left atrium, because if the atrial fibrillation is actually proximal atrial fibrillation and we know it is less than 48 hours, then maybe we can cardiovert that rhythm and the patient can be the cardiovert. So it's important to know the onset and then the further treatment. Okay, so let's discuss about the management. So management, I like to divide the management into acute treatment. Okay, so acute and then anticoagulation and long term. So first of all, acute. In patient with new onset AF with a rapid ventricular rate, so an assessment need to be made regarding the need for urgent cardioversion. So if the patient does not require cardioversion, rate control is recommended. So how should be your approach to the atrial fibrillation? Obviously, if it is a rapid ventricular rate, you know the onset is less than 40 years, provided there is no any contraindications, you can go for cardioversion. Obviously, if the patient is hemodynamically compromised, you'll go for the cardioversion. So first rate control agent include beta blockers or centrally acting calcium channel blockers. A goal acutely of less than 100 beat per minute is sufficient for a patient who is otherwise asymptomatic, hence a normal systolic function. And digoxin we typically avoided in patient for rate control. So rate control is recommended to improve symptoms and reduce the risk of tachycardia-mediated cardiomyopathy. Chronic tachycardia actually leads to significant structural change in the heart, such as ventricular dilatations. So often the tachycardia cardiomyopathy predisposed to further arrhythmias of the heart. Patients with heart failure with reduced ejection fraction can be difficult to rate control. You know that. Now, given that this patient has a symptoms for less than 48 hours, they should be considered for cardioversion to revert back to sinus rhythm. The decision to offer patient cardioversion, if they are otherwise hemodynamically stable, is dependent on multiple factors. So cardioversion in very elderly patient or patients with large left atrial dimension above 5 centimeter are normally, these are the patients we normally exclude, not for the cardioversion. Patients with the reversible underlying disorders such as thyroid disease, pericarditis, and post-op AF, they should be offered cardioversion. And these patients ideally should be young, less than 65, and have normal left ventricular systolic function. The absence of hypertension is also preferred. So finally, patients who have only developed atrial fibrillation recently and where it appears to be early in its nature history should ideally be offered cardioversion. These patients does not require maintenance antiarrhythmics. So patients with first presentation AF who have been cardioverted, they do not require antiarrhythmics such as amiodarone, flecainide, or sotalol in the first instance. So in patients in AF for more than 48 hours, cardioversion cannot be done acutely without a transvagal echo to exclude the atrial thrombus. So for patients with AF more than 48 hours in duration, 4 weeks of anticoagulation prior to cardioversion and another 4 weeks post cardioversion is required. This is to prevent any atrial thrombi causing acute stroke from embolization. Transesophageal echo we can use to screen patient for presence of thrombus if cardioversion is required before 4 weeks. So this was about the acute management. Then as I told you, we divide into 3 parts: the acute management, and then we come to the anticoagulation. So all patients with non-valvular atrial fibrillation should be assessed for stroke risk using the CHADS2 VASC risk tool, and bleeding risk should also be assessed in these patients. Now, patients with valvular atrial fibrillation should be anticoagulated with warfarin regardless of their comorbidities. So please note one thing, that this CHADS VASC score is only valid in patients with non-valvular atrial fibrillation. So it's a risk tool for the this is a CHADS VASC2. What does it stand for? C is for congestive heart failure, H is hypertension. Both of these will give patient 1 point. A is for age A2. The first A is age more than 75, we give 2 points. D is diabetes, 1 point. History of stroke, TIA or thromboembolism, we give 2 points. And vascular disease or history of MI, peripheral arterial disease is 1 point. Age between 65 to 74 is 1 point, and S is for sex category. If the patient is female, we give 1 point. So a patient with a non-valvular AF and score of more than 2 should be anticoagulated from a stroke prevention perspective. And a CHADS VASC score of 2, it actually represents approximately 2% annual risk of score, and a score of 6 represents a 10% score risk. Patients who have a score of 1, they are borderline and should be anticoagulated on clinical judgment. So then we come to the long-term. Long-term management revolves around managing the underlying etiology. So patient need to be optimized from a risk factor perspective, long-term hypertension, diabetes, coronary artery disease, heart failure, etc., to prevent further remodeling of the heart that may lead to AF. Because if you don't take care of these factors, the AF can be permanent. In patient with AF, the presence of heart failure, interventricular conduction delay on ECG, and previous MI are the greatest indicators for mortality. So furthermore, adequate long-term rate and rhythm control needs to be evaluated. If atrial fibrillation is recurrent, catheter ablation can be explored. So catheter ablation actually has been shown to be an effective method of maintaining sinus rhythm and reducing symptoms. So the primary benefit of this catheter ablation of patient remains for symptomatic control at this point. So in patients who have no significant structural heart disease but drug-resistant atrial fibrillation, sinus rhythm is maintained effectively with this catheter ablation. Atrial fibrillation ablation actually is associated with a significant benefit. Especially in patients with heart failure with reduced ejection fractions. So patients with symptomatic AF who have heart failure with reduced ejection fraction, they have high rates of mortality and morbidity. So if this patient have failed attempts with antiarrhythmic drugs, they should be considered for AF ablation, as this has been shown to reduce the mortality. So that's all about the atrial fibrillation. We have covered the investigations in detail, the history in detail, and the management. I hope you find it useful, but remember that this is just a starting point. Whatever notes or books you're following, just go through that and read about the atrial fibrillation. Quite common case, and I think it can be there in your consultation station. Thank you very much, and till next time, I'd like to take a leave.